Okay, Chair, the meeting's now live.
Thank you. Good afternoon and welcome to the Health and Overview and Scrutiny panel. I'm Councillor Ian Holder, Chair of the panel today. Members of the public are invited to view this meeting online. Those present are requested to keep their microphones on mute and only to turn them on when they're called to speak. Members are requested to keep their cameras turned on at all times. Officers and external presenters are requested to turn their cameras on only when they are presenting their reports or answering questions. If anyone would like to speak, please write your name and RTS, request to speak, in the chat function. Each time you speak, please say who you are so it's clear who is speaking. I'd now like to invite those present to introduce themselves. So, members of the panel. Firstly, Lee Mason, who was here a minute ago. Is he gone? Okay, we'll move on from Lee. Councillor Judith Smythe.
Councillor Judith Smythe, Ward Member for St Jude Ward, Southsea, present.
Councillor Rob Wood.
Councillor Rob Wood from St Thomas Ward, present.
Councillor Arthur Argate.
Hello, Chairman. Arthur Argate, East Hants District Council.
Thank you. Councillor Lee Mason, would you like to introduce yourself? No. Lee, can you hear us?
I can hear you, but until I see you, I'm not going to introduce myself. This is ridiculous, trying to do this on... I've been chucked out of this thing already. I know Councillor Atkins has also had problems, so he's been on the phone to me, so he's given up. So it's not a workable solution.
Okay, Councillor Atkins has sent his apologies. So we'll move on to Councillor Trevor Cartwright.
Yes, good afternoon. Councillor Trevor Cartwright, I'm Deputy Leader of Fareham Borough Council.
Thank you. And Councillor Lynn Hook.
Good afternoon, I'm Councillor Lynn Hook and I'm a representative for Gosport Borough Council.
Thank you. We've also got Lisa Gallagher from Democratic Services assisting today. Is there anyone else I haven't called? I think that's all the councillors. Apologies I've received so far from Councillor Rosie Rains, who can't make it today, and Councillor Matthew Atkins, who's having IT trouble as well. Number 2, declaration of members' interests. If any members have any interest to declare, please put RTS in the chat box and I'll call on you to declare your interest. No one? Okay. We'll move on to section 3. In the minutes from the previous meeting on the 18th of March, I think everyone received a copy of the meetings. So now we have to agree the minutes are correct and you're happy for them to be signed off. Do I have a proposer for that to be signed off?
Happy to propose, Chairman.
Thank you.
I think there's only 2 of us who are actually in that meeting who are here today. I'm suggesting we don't sign them off because that would be a decision and we can't do decisions online meetings. So I think that should be held back until we actually have a meeting face to face again. So,
Lisa, is that normal or is that okay for when we have face to face meetings?
We can defer it until we meet face to face. That's fine.
Yep. Okay. No problem. If everyone else is happy with that, we'll defer that. Okay. Right, so we'll move on to the reports. I'd ask anyone presenting the reports just to give us a brief update and let us know if anything's changed from the reports that have been sent out, and then we'll take some questions after that. So the first item on the agenda is from the update from South Central Ambulance Service. So I'd like to invite Tracy Redmond to give a brief update on the report.
Good afternoon, thank you, Chair.
Afternoon.
My name is Tracy Redmond. I'm the Head of Operations for South Central Ambulance Service in the southeast area of Hampshire. You will see from my report I've covered areas of developments including COVID, some information around our demand and performance, which also includes some additional information requested at previous HOSP for the Fareham and Gosport area. and some of our challenges and opportunities going forward. I think just to summarise, it's been an interesting year. It's fair to say in frontline NHS, as it has been, I know, for many people across various sectors. But we've had to change some of the things we do in SCAS, and we've adapted as we've gone along in line with national guidance, which in itself has been a challenge because national guidance has been changing and developing as we go as well. In terms of demand, the COVID demand has seen peaks and troughs, which has been difficult to predict. Again, we've had to adapt to that. And some different ways of working in terms of personal protective equipment, and some of our clinical practices and our deployments have been different due to COVID. So we have had some flexibility. We have had a number of challenges. The staff have been, as you would imagine, exceptional. It has been difficult, and we are still in quite a challenged situation, to be fair. We've also enhanced our leadership and support to our staff as we've gone through the COVID as well, to provide a more structured command and control arrangements, with a focus on making sure that the patients are able to still get the service. People are still having babies, people are still having accidents, people are still becoming unwell. So an absolute focus on trying to make sure that our patients are kept safe. We've had a lot of focus on our clinical coordination centre, which is where a number of our calls are now dealt with remotely via telephone triage. Obviously those calls that are suitable, where we're able to signpost patients to other services in the health and social care system, rather than dispatching an ambulance or rather than taking them to the ED department. So there's a lot of ongoing work around that, and that's to ensure that the patients get the right service and the right intervention for their specific needs. Rob, did you have a question?
Just very quickly, Chair, the chat seems to be muted, so we can't say we want to speak at the end. Sorry about that, to interrupt you, Tracy. Okay, I'll reserve it until you've finished, if that's okay with you.
That's no problem.
Should I carry on, Chair?
Yes, carry on, please. Thank you.
Thank you. So just in line with recognising that our most important asset to be able to deliver our services is our staff, and we've focused very heavily on keeping our staff safe as well in order to be able to carry on with our service delivery. And we've vaccinated all of our staff, starting with our frontline staff as per the national guidance, and then across to the rest of the organisation, recognising the really important roles that our support staff play as well within that. So we have now vaccinated all of our staff that wanted vaccinations, which is good as well. Alongside that, we've seen some huge acts of kindness from the public, especially during COVID, which has been fantastic, but equally difficult as well, because historically we've been able to perhaps receive gifts, which have been really nice, but during COVID, due to contamination, we've had to turn gifts away, and that's really difficult when people are trying to show their appreciation, and we're not able to always do it in the way we have done before. And the other one of the big challenges for the teams has been around, due to the COVID regulations, around not being able to bring relatives along in the ambulance, for example. It's very distressing for families and for patients where relatives can't always travel with them. So there's been some changes in the way we've had to deliver some of our services, and some of that's been quite a challenge as we've gone through COVID. And we've done a lot of learning along the way, I think, as have many organisations. It's not something that we've ever done on this scale before, it's fair to say. So that's kind of our year of COVID, really. Just moving on to our work with integrated urgent care, and I've spoken briefly about that, about how we're doing remote clinical assessments and some of that is linked in with our colleagues from primary care and other providers who are helping us with those remote assessments to make sure that those patients do get what they need the first time. So there's lots of joined up work going on there, and also working very closely with colleagues at Portsmouth hospitals around the challenges with the ED department and the offloading of ambulances, which some folk will recognise as a bit of an ongoing challenge there. We do work hard to not convey patients to the ED department because we do know they're under pressure and working really hard in there themselves. So we do continue to not convey around 50% of our demand, where those patients are either treated at the scene by the SCAS staff or signposted to alternative options other than ED. I've spoken briefly about our demand and performance. There's a chart there that illustrates our demand over the last couple of years. In fact, it ends on the chart, it ends at April. May and June are breaking records now in terms of demand, an increase in demand, and we're seeing now around a 10% uplift in demand to our 999 services in the last few weeks compared to where we've been at the same time last year and same time the year before. So significant pressure, and that's not a South East Hampshire challenge, that's a national challenge we're seeing from our colleagues across ambulance services and wider health and social care across the country. Is this quite a big surge in demand that we're currently facing? I did put on here our performance categories, which I've shared previously and have been asked for. And on the whole, we are getting to our most poorly patients in a timely fashion. So those are our category 1 and category 2 patients are the most poorly. And on the whole, we're getting to those patients in a timely fashion, which is good. There's always room for improvement, and certainly as we see the demand increase, we find ourselves more challenged getting to our lower category patients. Obviously, the calls are prioritised, as you know. So those lower category patients who are less unwell are ending up, unfortunately, having to wait a bit longer as the demand increases, unfortunately. We are looking at how some of those category 3 and 4 calls are being triaged, and we are triaging some of those calls as appropriate, again in our coordination centre, to see if we can find an alternative appropriate treatment path for those patients as well, in order that they're not so delayed. And just going forward in terms of challenges and opportunities, a couple of years ago, we embarked on a transformation programme which saw us changing our service delivery model, changing our rosters, changing our fleet, and some of the things, how we do things. So we're just now starting to review that, because that's been in place now for a little while. So we're in the process of reviewing our transformation process. And I've spoken briefly about some of our challenges around capacity with the current demand, which is unfortunately exacerbated by the knock-on effect of some of the queuing that we have at the hospital in terms of offloading our patients. But we are working closely with the hospital to see, and the wider system, to see how we can address some of those challenges. I think that kind of summarises my report. Chair, I'm happy to take questions, obviously.
Thank you, Tracy. I see in the chat, Arthur, you have a question.
Thank you, Chair. Tracy, nice to see you again. Petersfield is now an designated urgent care centre. Do you anticipate that this will bring some ambulance traffic to that particular facility?
Absolutely. So Petersfield has always been an option for ambulance traffic, albeit the criteria has been quite narrow. So with it becoming an urgent treatment centre, it allows them to be able to see more different types of patients. So certainly there's already a route in for ambulances there. So that has just made that more likely. More patients will be able to be taken there by ambulance, but there is a strict criteria that we have in order to do that.
Thank you very much.
Councillor Wood, you had a question?
Yes, sorry, Chair, I'm still having trouble sending mine. It keeps failing. But so if I put my hand up just to warn everybody.
Yeah, no problem.
Tracy, sorry, can I first of all pass on if you would pass on my personal thanks to your team during COVID. It was a fantastic job, and I think we really all appreciated you all being on the front line. That's really important to pass about. With the highlighting of capacity issues, which hopefully are temporary things, because obviously COVID is hopefully a once in a lifetime issue going on, and therefore, if you like, all sorts of things concertinaed. When you talk about capacity, because obviously as HOSP, we're really interested in knowing that taken from today, are we talking about a temporary thing, or have you looked at what normality looked like, why the reasons you've got capacity, and what your suggestions are to manage capacity, if you see what I mean, that you would like HOSP be aware of, and assuming, is there a time scale for that? Because at some stage in the future, you would expect it to go back to normality. So I'm really trying to grasp what COVID meant to you for your resources and what you're asking HOSP to be aware of in terms of how to manage that.
I think in terms of back to normality, we've gone back to normality and some. So the demand that we're seeing at the moment, the increase in demand is not COVID demand. It's business as usual, if you like, demand, but it is significantly higher than where it has been. So we're just trying to ascertain at the moment, is this the new normal? And if so, then what do we need to do about that? Or is it not? And there are a number of factors, I think, playing into that, which are being looked into. For example, primary care demand and how primary care is functioning at the moment. For example, the growth of, for example, Petersfield into the UTCs and how that will play into and how we're managing demand differently in our coordination centre. So I think we're still learning about. I think this may be the new normal, and I think we're learning now how we're gonna manage it going forward, because it wasn't expected at this rate. I think it's fair to say. So we're just now working through how we collectively manage that and work through that.
Thank you, Tracy.
Councillor Trevor Cartwright, you had a question?
Yes, thank you, Chairman. Yes, thank you, Tracy, and thank you very much for the performance or categories of Fareham and Gosport. Could you just run me through, just so that I'm reading it correctly, could you just run me through what it actually means in reality?
Yeah, so if I just quickly run through, so obviously the categories are clinical priority, category 1 being the most poorly, with the national standard of the time at which we need to have an attendance. And the mean is the current demand. Well, this was for April you've got here, but so the mean for the category 1s in PO12 in April was 4 minutes and 53 seconds against a target of 7 minutes. So a good performance on us. So the green ones are within national target, the red ones are outside of national target, and the black ones are not measured nationally, but we just measure locally. So they're in there for kind of information and comparison, really.
Okay, thank you for that. It's very helpful.
Okay.
Any more questions? No, I think that's it. Thank you very much for that, Tracy. I think everyone's read the report, and I think you're due back in November, so we'll see you again then. Thank you. I should have said at the start, anyone who does do any presentations. Don't feel you have to stay for the whole of the meeting. If you have better things to do, then you're free to head off.
Thank you. Thanks for having me. Take care.
Thank you. Next item 5 on the agenda, an update from Adult Social Care from Andy Biddle. Is Andy around? Yes. Hello, Andy. Could you give a brief update on the report and if anything's changed?
I will. Thank you, Chair. Good afternoon, members. So the report before you gives a summary of some of the main areas that Adult Social Care has responded to and worked within from the period from September of last year to May this year. I suppose reflecting, listening to Tracy, it's a very similar story, really, seeing peaks and troughs, seeing staff being reallocated and changing roles and moving into roles they're not necessarily familiar with, depending what the demand was at the time, and very much seeing Adult Social Care in a response mode to the pandemic, focused on those priorities that I've listed in the report. We've had to ensure that we've invested in staff support, common with SCAS and with other colleagues across the health and care sector. Staff have been stretched and have worked increasingly hard to try and protect people from harm. We've had to adapt to changing government guidance, and I've listed some of those areas of guidance in the report, often turning that round from receiving it into ensuring people are comfortable and confident to use it within a very short period of time, sometimes over a weekend, which was an interesting challenge for a lot of us. We've been supported and strengthened by our integrated working, both in Portsmouth at Place, with our health colleagues, with our voluntary sector colleagues, with the university, with housing, with all of those local services, but also in the integrated care partnership firm and South East Hampshire area, clustered around the acute hospital footprint, and ensuring that we can focus on hospital discharge and enable the hospital to do what it needs to, rather than think about different procedures between South East Hampshire and Portsmouth, for example. We've had quite a lot of work to do with social care providers, with care homes, with domiciliary care providers, trying to help them understand what guidance is coming out. They don't always have the infrastructure to be able to absorb that. So our communication with them has been increasingly frequent, and we've moved from different platforms, putting things out through a newsletter and a portal, and now we're moving on to Teams to communicate with our providers regularly. So we hope to keep that going as something that's come about through the pandemic. We've worked with people with learning disability, not only to help them understand what they need to do to stay safe, but also to encourage vaccination take-up for people who might have a real concern about going in for a vaccination. We've been really successful in that area. We've seen some fantastic work with unpaid carers. Portsmouth has punched well above its weight on the national stage in terms of contributing to national guidelines, ensuring that at regional level we're contributing a lot to guidelines that are shared across health and care services within the region, and culminating in a celebration of Carers Week a couple of weeks ago, where we had a great deal of bipartisan political support, and we were able to reflect on successes in working with carers, reopening services, making the carer centre accessible again, following social distancing. I think what we've seen is an increase in demand. It's been in peaks and troughs, but we see it settling now. So we're between 2.7 and 3% increase in demand for domiciliary care over what we'd normally expect at this time of year. We've seen decrease in demand for care home places, fueled partly by those people that tragically passed away in care homes during the pandemic, but also a reluctance for people to place themselves into care home care. And we need to work on a strategy to try and manage our market as a result of that. We've seen safeguarding pressures build in terms of adults who need protection from safeguarding and neglect. And that's what we're facing at the moment. And we're also seeing that we think 2021 is going to be an equally challenging year as 2020 was, particularly for the pressures on our health service colleagues. Tracy spoke about some of the issues with handover at the hospital. We've been getting more people out of hospital more quickly, and sustaining that is a difficult thing to do. We've had national funding that the local CCG has been able to claim back from NHS centrally, and that's due to come to the end at Q2. So we need to understand how we sustain the gains that we've made so that people can come out of hospital as quickly and as safely as possible, if necessary, into an interim environment to be able to make decisions about their onward journey. I've listed finally at the end of the report some of the challenges, not all by any stretch, that we think are facing us in this next year. I think it's probably fair to say that we anticipate juggling the continuing response in terms of the pandemic and coming back to some kind of foundation of business as usual, picking up those projects that we know long term we need to see through to try and make social care more sustainable in the city and to serve the number of people it needs to serve. And I guess whilst it's not possible to list everything in a report, even of this length, some of the things that are really focal for us are that integrated working piece with the advent of the integrated care system and Portsmouth's contribution to that and part of that, but also continuing to work strongly with health and social care, voluntary sector, our housing colleagues, public health locally, and strengthening those ties that were built on during the pandemic. And that's I think a summary, but happy to take any questions.
Thank you, Andy. I think the first question was going to be coming from Councillor Arthur Agate.
Thank you, Chairman. Yes. Do you? Sorry, I asked this question because I had an email from my MP a couple of weeks ago, which led me on to finding out that East Hants District Council combined with Havant Borough Council have a safeguarding officer, which is totally new to me, something I've never heard of. So the question is, do you liaise with our safeguarding officer?
I must admit to saying I don't know, Councillor. We have a lot of contact with the local authority safeguarding adult boards and the staff of those boards. So for Hampshire, the Isle of Wight, Southampton City, and ourselves. But I'm not aware that we've had any contact from East Hants and haven't. I can certainly go away and find out. That detail I wouldn't necessarily know, but happy to find out.
It's not a matter of finding out. It's a matter of, if you don't, why don't we? Presumably, you will cover that part of South East Hampshire.
No, we wouldn't. That would be Hampshire County Council, Councillor. So we do have a lot of contact with Hampshire County, but they would be responsible for safeguarding adults within that area.
Right. Thanks very much. Yeah.
No problem.
Just a bit of info for me.
Of course.
Thank you. Next question from Councillor Judith Smythe.
Thank you, Chair. I've got several questions here, which are provided in part by another newly elected councillor to Portsmouth City Council who's sitting in on this, listening to this meeting, and from a prominent member of the voluntary sector in Portsmouth. If I can take them one by one, I'd be grateful. Some of them will require a longer term, perhaps online information from Andy. I don't expect him to go through all the answers in detail this time. First question is about paragraph 5.2. With the 5.5 million additional funds distributed to the care sector in Portsmouth, is there any information on what proportions of this help support care homes, domiciliary care and day service providers? Do we have a breakdown? And also, is there any information on how those funds help to support the private voluntary sector and council-run provision? Are there any splits of that sort that you might be able to provide?
Yeah, we can certainly do that, and we can provide that as an offline response, Councillor. Yes, we did. So we kept because much of the national funding then required responses to the Department of Health and Social Care. We had to do a regular return. I think it was monthly on some of the grants and quarterly on others. So we can get you that breakdown, and we can share that with HOSP for the minutes. I
think that would be really, really useful. And what, in a sense, is behind all of my questions here, and I join these questions, I think, are good ones, is about the split between sectors in the way that the money was given out and what impact it had. So 5.3, how do adult social care work more broadly with the voluntary and community sector in Portsmouth? And I think it might be useful if you could just give us a summary there. That would be useful.
Of course. So in terms of the pandemic, we used one of our teams, our independence and wellbeing team, and some of our staff from our day services when they had to close initially. We redeployed those to support the Hive with their efforts around delivering food parcels, making sure medication was delivered to those people that, for whatever reason, couldn't leave their homes or were finding it difficult to get food delivered. That was funneled through the Hive because there was a national offer of food parcels, as you recall, and we expanded that locally to make sure that we're meeting the needs of local citizens. In terms of the wider relationship with the sector, we have several contracts with VCS organisations within the city. Salvation Army springs to mind, 5, 6, 7 others that I'm aware of, the Red Cross. And we're starting to work at the moment to consider how we manage those contracts, what they provide for the city, in terms, some of them for hospital discharge, some of them in terms of the increased level of loneliness and isolation that we're seeing for people, and how we coordinate that. And that's a conversation that we're involving the Hive in through our Better Care Fund procedures. So it's partly contractual, and then it's partly been response to COVID. There's also some core funding that we provide as a BCF, as a Better Care Fund, to enable the Hive to function and develop within the city, acknowledging that it's beneficial to the city to have an overall view of the voluntary and community sector and be able to not necessarily speak with one voice, but certainly speak with a coordinated voice. So that's the broad 3 areas I'd say that we're working with the Hive.
I think behind that question, and if Kirsty and Caroline want to take me up on this, but for me the question is about has the voluntary and community sector here in Portsmouth got proportionally more or less work, given the impact of COVID on the voluntary and community sector has sometimes been catastrophic?
I think that's a really difficult one to answer because it's often dependent on individual organisations. So I was having a conversation last week, I think it was, with Age UK in Portsmouth, and talking about how they've responded and stepped up contact services, befriending services with people, albeit remotely. So I think it will probably depend on individual organisations as to how that's worked out. We can certainly, what may be helpful is to provide, again, offline to HOSP for the minutes, to provide a breakdown of where we do contract with the sector and whether there's been a change in that percentage of contracting with through the pandemic, and we can certainly provide that information.
I think that would be really useful. And I'm sorry, Chair, there are 3 more questions. I won't, I'll do them as quickly as I can. They're on slightly different subjects now. Paragraph 5.4, there's an interest in how many hospital discharges are actually being dealt with via the discharge to assess initiative. And are there any figures to evaluate that? And again, I think we'd be happy to receive those later, but what's the general picture on that?
Yeah, it goes along 2 lines really. So yes, we've seen a lot more people than we'd normally see coming through the discharge to assess route, and that's both those people that will go directly home with some support because they're able to do so, or go to some kind of interim placement. As you'll be aware from previous briefings, we have the South Sea unit on the 1st floor of Harry Sotnick House, which provides a broad discharge to assess destination, where there's social work and therapy wrapped around, and people tend to spend a couple of weeks getting back on their feet and understanding where they need to go from there and what support they need. We've also, of course, had the Gun Wharf unit, again on the 1st floor of Harry Sotnick, which was our discharge destination for those people, designated premises, my apology, for those people who had a positive COVID status coming out of hospital and couldn't go on to another care home environment without 14 days isolation. So that designated premises was provided under guidance, under government guidance. We've also seen a reduction in lost bed days, and I think Susanna Rosenberg, when she presents Solent's report, will talk to that in some more detail. I haven't got a chart for that in my report, but equally we can get one. And so we've seen people be delayed for less time coming out of hospital. So those are the big 2 increases in business hospital discharge wise. And yes, happy to provide those figures. That's no problem.
Thank you, Andy. What on paragraph 6.5, what explains the large increase in police referrals for safeguarding? That's quite a big jump.
It is. We're not entirely sure, to be entirely honest. It is very significant. I think what we tend to see from an adult safeguarding lens is colleagues in other services, including the police, are concerned about someone. We look at these referrals when they come through and we don't necessarily regard them as safeguarding. There's a reasonable criteria for what safeguarding would be, but still acknowledging that somebody was worried enough to want to let someone else know that this person was at risk of something. We think it's probably related to easing of lockdown, easing of restrictions. As life gets back to normal, people move out of environments that have been very closed environments for a long time. And whilst it doesn't necessarily tip the threshold for neglect or abuse, there's more people seeing that people may be at risk because there's less restriction on contact. That's a very broad category. I'm afraid it's not really as scientific as we might like, but until we look through all of these, until we understand and are able to categorise them, that's probably as precise as we can be at this moment.
Thank you. I mean, that would be something Councillor Kirsty Mellor, who's newly elected, is now going to be the sort of champion for domestic violence in particular. Yeah. And it might be a useful conversation for you to have, and I'd be interested in hearing the answer too.
Happy to do.
Now, there's just a couple more. I'm sorry, Chair. Thank you very much. One is there's two interesting bullet points in your first paragraph, 6.7. Increase co-production to shape provision, something which, as you know from my work experience, I'm passionate about. And second of all, support and influence building capacity in communities. What do they actually mean? What will actually happen different as a result?
The intention for us in terms of co-production, it's probably best to give a practice example, really. We recently tendered a contract for the support provided to people living in extra care. So as you know, extra care is where you have your own front door and your own flat usually, but there is support on site as and when you need it. And when we retendered that contract, we asked some of the residents who live in those environments to help us with that, and they had a casting vote on the provider who won the contract amongst all of the other procurement bits and pieces that we need to follow, regulations that we need to follow. So that's an example of co-production. Equally, working with people with neurodiversity or on the autistic spectrum, we've recently been able to gain some funding to work to create support groups and help support groups to flourish and grow so that people can access them independently. We're providing the funding, but we're not dictating how that works. We're asking people to tell us what's most useful to them and how that develops. So those for me are a couple of examples of co-production. Not only how does the service look and who provides it going forward, but how is the service actually designed? And what we'd like to do is see that for all of our contracts, all of our services. It's obviously a big journey to take, but we think that's something we need to do. In terms of building capacity, I think that's more difficult a concept. So we know, especially in Portsmouth, where you've got very individual and very people identify very strongly with the part of the city they live in, their community. And we know there's lots of services and support available in communities and connections that can be made between community groups that could make those even more accessible to residents. Now, we know we have a funding challenge in social care. It's reported in the media quite regularly, thankfully. It never used to be, but thankfully it's more recognised now. But we know whatever national plan we see, if we see a national plan, we're still going to have to rely more on people and their resources and how they use them, not to deny them care, but to ensure that the care that we purchase on their behalf or that they purchase with funding is proportionate. And so that building capacity between communities is something we're really interested in. There's places like Bath and North East Somerset have done that remarkably well. Leeds has done it remarkably well. We've got quite a way to go in Portsmouth, but that's the journey that we want to go on, which is identifying and linking those community resources. Sorry, yes, when I reread those this morning, they sound a bit jargonistic, but that's what they mean to us.
They go hand in hand, of course, don't they? It's about making sure that you don't have a visit to do your toenails on the day that you go to your church or your mosque for a routine thing that's really important for your well-being and social life and all those things. It is about actual co-production of the life that somebody wants to lead, isn't it? Thank you for those. The very last one is, I think I haven't been on, I used to work to set up HOSPs in the past, so I know what they're meant to do and how they do it, but I haven't been on this before. But I was surprised in a way not to see more in your report and some of the others about what are the issues, what are the things we should be worried about. If you had a magic wand, what are the big challenges going forward in Portsmouth from your perspective? What are the things that we should be worried about?
I often reflect that my magic wand's in the dry cleaners, but I take the point. I couldn't really, and I know you focused it on Portsmouth, I couldn't really let that go by without talking about a national plan for adult social care. We can't keep relying on council tax rises to fund adult social care. It's not proportionate. It creates a huge amount of difference across different areas. It doesn't take account of inequality. So we need a national plan for adult social care. We need not the same, but a similar kind of infrastructure that the NHS benefits from in terms of workforce, in terms of how we're going to fund services going forward, and whether we continue to charge for adult social care. If we do, is that proportionate? The guidance is fairly old now. The Care Act, the last major piece of legislation, was 2014. And we didn't implement part 2 of the Care Act, which talked about what people would pay as a maximum in their lifetime and all those kind of things. So a national plan is genuinely what we need. And certainly the Association Directors of Adult Social Services, the local government association, provider associations are all clamouring at the moment to see that plan. I think for Portsmouth, one of the things I'm concerned about going forward is that 3% increase in domiciliary care. It doesn't sound a lot, but when you set that against around about 1,100 people, and I commented in my report about the categories of cost that we see in domiciliary care, that's going up. We are seeing increases in the higher categories of cost. So purely from a funding perspective, I'm very concerned about that. We're going to have to work hard this year to try and figure out how we manage that, if that's an embedded position. I think one of the things I'm really concerned about is the strain on the NHS this year. I think juggling elective, absolutely necessary and essential elective surgery opportunities for people who are finding their lives curtailed because they've not been able to have that surgery. The strain and pressure at the hospital in trying to maintain that flow out of the back door for people to ensure they can focus on people who are critically ill. And the work that we all have to do as health and care community in Portsmouth to stop people getting to the hospital gates unnecessarily. Tracy touched on that in her commentary earlier on, and she's absolutely right. Getting the right care at the right place, right first time, is something that's a responsibility of us all, and will be a huge challenge because we're joining up organisations to do it. But is one of the key wins that we could gain in the next year. I think for adult social care, getting domiciliary care in a more modern and responsive place. We've had a project on dom care, but it's been delayed by COVID. We want to move to ensuring that people and their families, where they wish to, can tell us exactly what they need on any given day, so that we're not seeing standard blocks of time for domiciliary care. It's far more responsive. I think the care home sector is of concern because of that change in placements that we've seen and an overcapacity in care home places. And managing that is going to be very difficult and challenge us a lot this year. I'm challenged by staffing, but then I think any department in the council and any NHS colleagues could say that. I think we struggle with capacity to be able to manage all of these priorities. That's probably enough of a list, I suppose, but those are the things certainly in my mind at the moment.
Thank you for that. Given the importance of the national reform of the social care system that the government appear to be considering at the moment, is it the sort of thing that we as a health overview and scrutiny panel should be doing, is writing to ministers to say this is a real priority in our area, to move them to action, or is that not something that we would do?
I don't know. I think it's something we could do. I don't see any reason why not. I'll talk to Lisa afterwards and we'll see what we can do.
I mean, we'd need to be reasonably agreed on that. Perhaps a little show of the hands to say, do we want that to happen or not?
We'd like a show of hands if we'd like to write to the minister involved. Yes, I think.
Looks like we're all agreed. That's great. Very helpful. Thank you.
Thank you. We'll get something sorted.
I'm finished now.
Thank you, Judith. Rob Wood.
Andy, I think in that very long stint there, you covered most of my points. I just want to actually feedback a view, which is the words co-production, working with the third sector, should include helping them bid for money, because the councils can no longer be the, feeding pool for everybody. And we do need to make sure we don't cut them loose. In other words, many of these people will make a bid, and it's in our own interest as councils that adult social care and the others help them bid for it to make sure that is sustained. That's one of the areas I'm a bit concerned about, because everybody is suffering coming out of it, and everybody can't just look to councils to solve the problem. We need to give our strength in the way we can to help them bid for it. The other thing is about what are the focal points. You said quite a few things there, so there were a lot, and it'd be great just to prioritise them. One of the things I noted was Tracy saying she was looking at the reasons for the increased amount of traffic with people going in, and usually they go out somewhere. So I'm hoping that in your talks with your colleagues, because we know the CCGs may change and all of that, lines of communication now are going to be very important. So what goes into hospital comes out somewhere, and I'm just sort of saying, a bit like COVID, if the figures are rising going in, somewhere down the line, there's a consequence of it. And I hope you're keeping a tight eye on that. That's what I've got to say, Chair. It's really, everything else was covered in that feedback Andy's just given.
Thank you, Andy. That was a good presentation. Thank you for your time. And I think we'll see you again in November, I think.
Yeah.
Thank you
for your time.
Item 6 on the agenda, I'd like to invite Sarah Ivory Donnelly from the Care Quality Commission to present. If you could just give us an update and see if anything's changed. Thank you.
Hi there. So I'm Sarah Ivory Donnelly. I'm an inspection manager here in Hampshire, Portsmouth, for CQC. And as far as an update goes, I think when I come, it's a little bit different from some of your other presenters. In the past, I've come first to tell you about kind of how we changed inspections. I've come to tell you about recent inspections at Portsmouth hospitals. And today what I've come to tell you about is some of the work that we've done looking at systems. So I think it's great I'm following Andy, because I didn't catch his whole presentation, but it is demonstrates the timeliness of that. So I was asked not to give you a presentation, but I'll just give you a little bit of background information. I know you've been able to have the opportunity to review the national report, and then I'm happy to answer any questions that you might have if you're happy with that. Okay, so as you will be aware, over the years we've changed the way we inspect and look at different providers, and historically, and still for the most part, we look at providers and their locations. So we have providers and we inspect locations, and we engage with those providers at both the provider and location level. Where we have concerns, we cross the threshold and go and inspect, and that's when you see sometimes our reports. However, one of the things that's really been highlighted in recent years, and even more so with the impact of COVID, is that the way systems work have a huge impact on our healthcare providers and whether and how they can do their jobs. The sort of classic example of that is, if, as Andy said, people aren't getting the care that they need in the community, they go to the ED, and if those people, if the hospital is not getting people back out into the community, people in the ED wait for a long time because of what's going on out in the community. So it's all one system. So what we are starting to look at as an organization is how we can look at systems as a whole. And we've done this in a couple different ways in the past few years, but most recently we've done, provider collaboration reviews, where we've looked at how providers across the system are collaborating. Most recently, we've done a series of reviews, one of which was the urgent and emergency care review, part of which was rolled out here in Hampshire and Isle of Wight. And what we really looked at is how each of the different types of organization was collaborating and what the impact was. And Hampshire and Isle of Wight, so I'm not here to talk about specifically the outcomes of that review in Hampshire, but more specifically or more broadly about what we saw in the nation and how this may carry through. So looking, basically we focused on the systems, and we focused on where systems are working, where they aren't. One of the areas we particularly looked at that we hope to focus more and more on, both in our monitor and inspection and across systems, is inequalities. So in our review, what we found nationally is, without telling you what's in the report, because I know that you have read it, is that there is a lot of difference across the nation in the way people are receiving their urgent and emergency care, whether they're able to access the care they need in the community so that they don't have to go to the urgent care, what their experience is once they get to hospitals, and that depending on who they are, where they come from, and to some extent whether they're BAME, whether they have other issues, concerns that make them vulnerable, they're getting different levels of care across the country. And different systems work differently. So it was exciting to see that in the Isle of Wight, it's still, you will have noted, or excuse me, Hampshire Isle of Wight, you will have noticed they talked about the fact that it's still 4 separate systems that are coming together, but that there's been a lot of progression towards system work. And so essentially that they, like the rest of the nation, are progressing forward. I'm not here really to talk about the specifics within Hampshire and Isle of Wight because we haven't been able to publish those, but really just talk about that and let you know that is our future. So that whilst we have historically only come really to talk about the inspections that you will have seen at Portsmouth hospitals and the other areas of care that CQC looks at, we are looking more broadly now and trying, like the rest of the nation, I think in some ways, to figure out how we can bring our systems together to provide the best, or support providers to give the best care and be responsive. And I'm sorry, just because I was told not to do a presentation, that's just a very quick little overview. But if you have questions, I'm very happy to take them.
Thank you, Sarah, and thank you for jumping in at the last minute when Claire couldn't make it.
No problem at all.
Councillor Arthur Agate, I think you had first question.
Thank you, Chairman. It's not so much a question as to make the point that you're focused on safeguarding.
Arthur, you've muted yourself. You've muted yourself, Arthur.
Just take the damn thing off the spot. Okay, well, it's really to say you're focused on safeguarding. I received it extremely well, and East Ancestry Council and Havant Borough Council are going through the process, because I'd never heard of it until about 3 or 4 weeks ago. Safeguarding was a new concept, but it's a pleasure to see this. It's nice to know that East Ancestry Council and Havant Borough Council are making note of this and making inroads into it. I've done 2 sessions of it now, so I'm told that I'm good for another 2 years, which is extremely happy to know. Thank you very much.
Thank you.
Thank you. Next question, Rob Wood.
Sorry, Chair, very quickly. Sarah, just very quickly, obviously as your independent regulators and you go around and see, you have a look at the systems and you point out what's good and what's bad. To stop the reinvention of the wheel, one of the things that we always like is to get to the point. Now, when you normally have your reports, they're very detailed, and finding the learnings and the context is very difficult. One of the things I would really love is to avoid us reinventing the wheel everywhere we go. Considering you're a body that has quite extensive overview, I think one of the things we would like is for some consistency. So you said lots of people are doing it different ways. Now, there may be a local reason for that, but there derives an independent view of what is working. It'd be great as part of the Care Quality Commission's view is to have a master book of best practice, which condenses all these on a changing basis, that is accessible to the public and practitioners, so we both can see what we think is good practice, because you're out there measuring it and reporting on it.
So one thing I would say about that, well, I have a number of things I could say about that, but I won't bore you. First of all, I would say we do several reviews per year that focus on different areas. Well, I think one of the recent ones, for instance, is dental care, where we try and pick out nationwide what's working and what isn't working. And so that's one way where that's done. There will probably never be a guidebook about what best practices be, for a very specific reason, from the CQC, because CQC doesn't tell people how to do what they're doing, because that would stifle innovation, first of all. And secondly, it's not really our role. That's more the role of the GMC and all of those specialist colleges. But I very much agree. And I think one of the directions CQC is going in is to highlight not what has to be done, but what best practices are, because we want organizations to be able to to learn from each other, but likewise, as you say, sort of across the nation, to be able to highlight those issues where it may be that Southampton is never going to see what is going on in Sheffield.
I think, Sarah, all I'm trying to point out is translating in English that everybody understands. When you say what are the learnings, okay, you're in a way pointing out, what did you learn from that, and then you're going to highlight things that look like good practice. And I think just turning that process also into something even more beneficial to the public and the practitioners is quite interesting, because sometimes people don't talk in the same language.
Definitely. And so it's a real focus. I as an inspection manager, I review a lot of reports, and one of my focuses is that in a language everybody can understand. I know we don't always quite capture it, but it's very much on our agenda. And watch this space, because our reports are changing somewhat, and they should be somewhat shorter and snappier and highlight what is particularly good or particularly not good, rather than spending a lot of time. Anyone who's read one of our reports knows we can spend a lot of pages on what's is basically fine. So thank you for that.
Thank you. Next question from Councillor Judith Smythe.
Thank you, Chair. I've got two slightly related questions. I mean, I found reading your report was interesting, Sarah. I was surprised not to see a bit more clarity that when you say something is working well, you're doing so because it produces better health outcomes for people. You seem to leave it slightly in the open what you actually mean, whereas I'm only really interested in outcomes in terms of morbidity and mortality. It's all very well to say, I mean, in my working life, I did quite a lot of these sort of reports. It's all very well said this is very nice and cozy and working well, but unless you bed it down and say it's working well for patients with reduced morbidity and mortality, then I start to feel I'm on very thin ice indeed. Do you bedrock your judgments on outcomes? That's the first question. And the second one is,
I'm going to take the systems work that we've done separately, because the systems work that I was just talking about, no. I mean, to some extent it was one element, sure, but we were really looking at, in the middle of COVID, what seems to be working and what doesn't. More generally, yes, when you look at our reports, the effectiveness is one of the 5 areas that we look at, and is one of the areas that is likely, those numbers are likely to bring a inspection rating where things look good. That's one of the main things that will bring things down. And particularly, we're talking about ED, and particularly in the world of ED, but certainly not exclusively by any means. So it is definitely a focus generally in the work that we do.
But not
Does that answer your question?
Well, I think it's as important to measure the effectiveness of a system, and it's very difficult to do that because systems should be what commissioners are commissioning. They're not just commissioning services; they're commissioning the way the services work together and how the system works. Anyway, I'll leave you with that. It's a long thing.
Can I answer one part of that, which is really, you have hit a huge nail on the head, which is we don't have the power at this point to comment on commissioning. So that is one of the reasons when we look at systems, we have to look, or we were able to look using certain powers. I think it's section 54. But we don't have the same powers looking at a system that we do today. We don't have the same powers looking at a system that we do when we look at an individual provider or location, which is why we can delve into certain things at the location level that today we can't at system level. Now, I do understand that may change, but for now, that is part of the reason we can provide feedback on the system, but not.
So, okay, I won't pursue this one. People can see where I'm going. People know about my obsession with outcomes. And I'm a bit appalled by what you say. The question I wanted to ask now is from somebody, these other two people who are interested in listening in. Is there any way you can summarise for us the main lessons that can be drawn from the report for Portsmouth and South East Hampshire? And equally importantly, are the findings for Portsmouth similar to South East Hampshire, or are they completely different because they are commissioned and provided differently?
They are, but we haven't published separate reports. So at this point, no, I'm not able to report to you on breaking out their information.
Okay, Hampshire and the Isle of Wight then. What are the lessons that we need to take into account as a system in the southeast of that area?
So as I said, what we've published is a national report. So that's what I'm able to report to you on. I think we have fed back directly to the system. And what I would say is, I don't think there were any huge surprises, but I'm not able to report to you on unpublished sections of the report. So what I'm able to tell you is feedback on is what's within the national report.
So are commissioners able to get hold of the details and take action as a result?
Yes. Well, the system is, and the system has had that feedback, yeah.
Thank you.
Thank you. Next question is Councillor Lynn Hook.
Thank you, Chair, and hello, Sarah. My question is on oral health, which I think is very important, and people have been in a lot of pain over this COVID period. We in Gosport had a dentist who, from really very early on, opened his doors certainly to emergency work, and then very early on got everyone in for checkups. And I just wondered, I'll see on your report there's quite a big difference over the areas, and I'm just wondering whether we're going to learn from the ones that could open early and what they did differently to the others that weren't prepared to open.
Sorry, I'm not quite sure. Are you asking me what the difference was between each of those individual? I'm not quite sure about what the question is.
Not every individual, but in certain areas, people or dentists were prepared to open for an emergency appointments and then very early on for checkups, whereas others are very reluctant even now to open. And I just wondered over the area how varied it has been. And also, are we going to learn from the dentists that have opened early in case we go through another lockdown? I hope we don't. And just, are we going to learn from the ones that actually took the plunge and opened?
I have to tell you, I don't know. I can definitely tell you that there, as you rightfully say, were discrepancies, and that it was an area where a lot of people didn't get the care that they needed, without question, across the patch. I don't know if dental has gone more specifically into looking at the differences between those providers, but I'm more than happy to go to my contact in dental and or oral health, they now are, and see if they're looking more specifically, because it certainly strikes me as a reasonable question. So if you'd like, I'm happy to report back on that to you.
Lovely, thank you.
Thank you. Were there any more questions? No, I think that's it. Thank you, Sarah, and it'd be good if you could report back to us on dental care.
Yeah, no, writing myself a big note.
Thank you for your time.
Thank you ever so much.
Thank you.
Take
And
care.
moving on to item 7 on the agenda, Hampshire and Isle of Wight integrated care system, and I'd like to invite Richard Samuel to give us a brief update and let us know if anything's changed since the report.
Yeah, thank you so much, and thank you for the invite back to the Overview and Scrutiny Committee. So, as the paper stands as an update on the programme around the development of integrated care systems, which will be replacing the statutory clinical commissioning groups and a range of other national architecture around planning and delivery of health services. The paper gives a very, very brief overview of the architecture of integrated care systems as we anticipate in the forthcoming legislation, of which we anticipate the first reading of the bill will be in early July, with second reading in later July. The only update to report relates to the release of what was called the ICS design framework. At the time of the publication of the papers, I think in the deck we allude to the fact that we were waiting if it was expected to be on the day the papers were published. It subsequently came out late last week. So that design framework has now been released, and that is a kind of cornerstone guidance that will allow us then to start to work to co-produce the future arrangements for the integrated care system for Hampshire and the Isle of Wight, and we can expect supplementary guidance around a breadth of areas, from everything from governance, constitution, through to financial flows, through to place-based arrangements over the course of the next month or so. So we've been working hard around our engagement process, listening to feedback from key partners. We've been doing baseline mapping of current arrangements in place across all of the units of planning and delivery in Hampshire and the Isle of Wight, and building a headline system development plan, albeit awaiting the further release of guidance as we move forward. Final thing just to say, which is very relevant for Hampshire and the Isle of Wight integrated care system, probably slightly less relevant for the Portsmouth community, but we await a decision from the Secretary of State with regard to the boundary of the Hampshire and the Isle of Wight integrated care system. In North East Hampshire, the population is currently under the Frimley integrated care system, but there is a proposition that there is coterminosity between upper tier local authority boundaries and integrated care systems, and therefore we're awaiting a decision from the Secretary of State as to whether the North East Hampshire population will be returned under the auspices of the Hampshire and the Isle of Wight integrated care system from April 2022. So I'm really happy to answer any questions. There's an awful lot of work going on, but that's a very high level summary of the current state.
Thank you, Richard. Does anyone have any questions? Councillor Smythe.
Thank you. I've got a couple of questions. Hello, Richard. Nice to see you again.
Hello.
We got
Lovely to see you.
about 20 years ago, didn't we? It was very nice to see you. I'm asking, first of all, a question from the small group of people who I know are listening to this call. What kind of organisations are likely to be involved in the provider collaboratives? Will not-for-profit providers be encouraged and supported to join?
So the provider collaboratives is a title given to a fairly broad church of enterprises, and I would imagine, and they are self-creating as opposed to mandated nationally or indeed regionally or locally. So I would envisage and imagine that third sector and other partner organisations will undoubtedly be part of some of those provider collaboratives, but I can't yet confirm because we're still in the development phase around all the provider collaboratives. What I can say is those that I know that exist. So there is undoubtedly an acute physical health provider collaborative in development, which is looking at where There are opportunities to drive quality and efficiency through collaboration around, for example, a pathology network, a single pathology system, a single procurement process, those sort of endeavours, a single diagnostic network, ensuring there's a single data system for diagnostics. We anticipate that there will be provider collaboratives operating across mental health and learning disabilities as well, and I suspect that's going to be a more fertile area for third sector partners to be involved in as part of a delivery solution. Interestingly, in the legislation, we anticipate, but we haven't yet seen the draft legislation, significant changes in the procurement regulations associated with health, the health sector. That won't in and of itself affect adult social care or children's services, but it will affect health. And what that will do is will allow the integrated care system to make decisions or delegate that decision to partners, which avoids potentially the need to make procurement decisions and can allow for more direct award decisions as long as there is justification, transparency and due merit. And that might well be something, Councillor Smythe, that the our partner sector, our third sector and voluntary partners would be quite gratified to hear, because we do know that procurement can be a huge barrier to access for small scale organisations able to move quite agilely.
I mean, it sounds to me, and I'm increasingly sceptical as I get older and move into the role of an elected councillor, that some of this is a absolute recipe for for-profit providers to get together in big boys' rooms and for the third sector to be neglected, overlooked, and not be part of the system. And also, I do think that these provider collaboratives could be very much closed shops and could lead to less public engagement, because my second question is about public engagement in these processes, and indeed about the hopes that we've all got for integrated provision that would lead people being able to commission integrated systems where integration between providers is part of the work that can be done using individual budgets, people co-producing outcomes from themselves, the outcomes they want, not the outcomes that some for-profit provider wants. Could you make a general comment on that?
Yes, so you'll know, and I'd be really happy to bring a brief or ask a colleague to attend, to say that Hampshire and the Isle have been leading the way nationally on the development of personalised care for our population. And we are seen as a national exemplar now in the number of people we're supporting with personalised care budgets. We think those are incredibly powerful. There is limited point in progressing down the process of building an integrated care system if patient activation, patient empowerment and citizen activation and citizen empowerment isn't at the heart of it. There's no doubt the integrated care system has 4 core aims, and 3 of them are absolutely orientated towards tackling inequalities, empowering citizens and building social and economic growth for the local communities. And that changes the dynamic a little bit away from a health organisation which is absolutely single-mindedly focused on activity and delivery to one more orientated towards ensuring collaboration towards improved outcomes for local people. And you only do that by working with them. So over the course of this year, it's going to be incredibly important to ensure we hardwire people and the citizen's voice in the development of the partnership, which is the architecture which will set the overarching strategic ambitions around health and wellbeing for the population of Hampshire and the Isle of Wight, and then a test to ensure that the citizen's voice is exhibited in all elements of the ICS. And of course, the ICS isn't just one thing; it's a collaborative structure of which the arrangements in Portsmouth are going to be fundamental. So we have a design principle now that's been collectively agreed, which is that our focus for the next 9 months as we move towards becoming an integrated care system is simple, evolutionary, local where possible. And I think within that should be a sense of reassurance for partners within Portsmouth who've got a very strong legacy of local place-based planning and delivery for your population.
Yes, we have got an exceptionally good system of integrated planning, if you like, commissioning, if you want to use that word, and delivery. But I still think we could do better with the involvement of citizens and carers, and I still think we could do better with measuring the effect of those systems on outcomes in terms of morbidity and mortality, and people's feedback on whether they can live their own lives the way they want it, or whether they it's not making much difference. I won't. Thank you for your answer on that, Richard, and perhaps we should have another discussion about this now that I've got involved from another perspective. But it is fundamental that particularly the Health Overview and Scrutiny panel is able to ask questions about outcomes for patients. What else are we doing if we're not doing that? And engagement and making people feel that they're co-producing the systems and the services that make up those systems is a really important part of this. And just my last question is, the health and wellbeing boards do to some extent represent some of those interests through the involvement of the third sector and other things. Will they still have significant power in what you call planning and I call commissioning?
Yeah, so we don't anticipate the legislation is going to change the legal duty to establish health and wellbeing boards. And we've been working with the health and wellbeing board chairs and the local authority chief execs. All of our 4 local authorities remain committed to the principle of health and wellbeing boards being the core architect of identifying the population needs and setting the kind of strategic objectives of place. So we anticipate, and the guidance as it comes out is clear, that the 4 health and wellbeing, any work undertaken at Hampshire and the Isle of Wight has to build bottom up from the priorities established in place, and that comes straight from the Portsmouth Health and Wellbeing Board. And I would, as a addendum to that, because I've heard the focus on outcomes being debated over the last 2 previous agenda items, would signal it would be really timely for the Scrutiny Committee to call in for a conversation about population health insight and capability. We have just now mobilised a population health management function across Hampshire and the Isle of Wight, working with a partner called Cerner and Optum, and we're piloting in a number of primary care networks in Portsmouth an insight model that allows to track experience, access and outcomes for a population, identifying where individuals might be experiencing fewer inputs and fewer access points into health, and tracking whether the outcomes experiences are greater or lesser than we would anticipate given their holistic care needs. So that's for us is that's a 4 mile moment for us in terms of the change in setting the barrier much higher now, and about our capability to track outcomes, which hitherto, as you'll know, Councillor Smythe, has been limited to access tests. Now we can look at the individual, all points of interface, be it primary, social care, acute care, pharmacy, dentistry, and even some other agency data aggregated to enable us to understand who isn't accessing or experiencing positive support and who isn't, therefore achieving the outcomes that they're able to achieve.
Thank you very much. Oh, that's really interesting. Chair, if we could make sure we do put this on our agenda, I'd be very grateful. I think that's an important thing for us to look at, and a good way of us, as the Health Overview and Scrutiny Panel for South East Hampshire, to be able to have a bit of a baselining on our expectations going forward with our agendas.
Yeah, I agree with that. Thank you. Councillor Wood.
Okay, Richard, very quickly, really, this is just a specific question about the Guildhall Walk, just to follow through. Part of the Guildhall Walk, they had a special allocation scheme going on there. These are people who couldn't get into other practices, and obviously they're the cohort potentially unlikely, would be very difficult to be spread amongst others. Can I just check how we're going to monitor that? Because The others obviously will be absorbed, hopefully, but this group that was already difficult to absorb, I'm just trying to work out how you're going to monitor that.
Yeah, so Councillor, can I ensure that you get a response to that? I'll check in with my colleagues who are working explicitly in Portsmouth CCG at the moment, who'll be monitoring that outcome. And I'm not, I'd be speculating if I were to say now, so I can ensure there's a response given directly to you in short order.
Thank you, Richard.
I was going to ask the same, so I'd be very happy to receive that too, please.
Fantastic.
Thank you. Any more questions? No. Thank you, Richard. Thanks for taking time to update us.
Thank you very much.
Thank you. Moving on to agenda item 8, Solent NHS Trust update. I'd like to invite Susanna Rosenberg to give a brief update on reports and let us know if anything's changed since the report was written.
Thank you, Chair. So the only thing that I particularly wanted to draw your attention to is the Jubilee House update, because I know HOSP has been particularly interested in the future plans for Jubilee, and this is something that we've been updating you on for 18 months probably now, because our original plans were delayed by the pandemic. So things have changed in Portsmouth in terms of the way that we work and what we think that we now need, particularly with Portsmouth City Council opening the top floor of Harry Sotnick House for D2A provision, which has been a real benefit to patients being able to come out of QA hospital in a timely way. And we are, I think, fast approaching the point as partners in the city to be able to say what the best configuration of community beds is for our population. So my question to HOSP, if that's okay, is how would you like to receive a contemporary update from those conversations, given I can't give it to you today because we haven't quite concluded those conversations, but we will be concluding very shortly. And equally, I don't want to wait until the next HOSP meeting because I think that that wouldn't be timely for you. So I'm wondering whether or not an email update would be okay for you all.
Yes, I'd be happy with that. Does everyone else agree?
Chair, can I make a suggestion? An email update, and then at a meeting, we just have a point that says, did everybody read the email? I know it sounds stupid, but you need to cover both. Because those who say, no, I didn't wish email, you know,
yeah,
you can chase them with the email. So I'm happy with an email, but we've also got to remember that members can be very human and may miss it or not read it, and therefore a prompt at a suitable time, just so that they do catch up and you could say they've read it.
Yep, good idea.
So happy to answer any other questions.
Do we have any questions for anyone? No, I think that's it. Thank you, Susanna.
Thank you, Chair.
Moving on to item 9 on the agenda, the Guildhall Walk Healthcare Centre update from Joe York, and I think Joe has agreed to answer one of the previous questions.
Yeah, I can do that as part of the update, Chair. Thank you. So, report that you've got following the last meeting of HOSP outlines the plan and the process the CCG has undertaken to engage with patients and to provide to ensure a managed transfer with as minimum disruption or work for patients as possible to alternative primary care provision in the city. So the report outlines how we did that, and that process is ongoing. And also the support that we will provide through that process to vulnerable patients, in particular the homeless population. And I can also talk about the special allocation service that was mentioned earlier. So we are midway through the transfer process. We sent letters to all of the patients back in May, asking them to express a preference for their preferred alternative provision. 1,075 patients responded expressing a preference, with 6,500 choosing to have that allocation done on their behalf. We are now looking at that, working through that with our CSU colleagues, the outcome of that survey, ensuring where we can really, that those patients that did express a preference receive that first choice, and then looking at how we allocate those other patients on the basis of their the surgery nearest to them, but also making sure that that capacity is evenly spread with practices, and working very closely with other practices to ensure they do have the capacity and support required to undertake that transfer process. We envisage that that will be completed by the end of July. Particularly within that is the support for vulnerable patients, and by that I mean some of the homeless patients, but I'll come on to them in a moment. People who may be housebound, any end-of-life patients with learning disabilities, for example, to make sure that we've identified those and we're working with the practice to tailor communications that will best meet their needs. We've also got a mechanism to flag patients with ongoing support needs to the new practice, so that there's no delay or risk of patients not receiving that care. For example, that could be daily wound dressing, for example, on that, and again, end of life care, which is extremely important. One of the issues that the patient engagement and questions and concerns from the patient engagement sessions that we held was around medication, and ensuring that there was no delay in repeat prescribing and receiving those ongoing medications, repeat medications. So our medicines optimisation team are working really closely with the Guildhall Walk provider and the receiving practices to ensure that, again, that's flagged and there are no gaps around that. There's between 70 and 100 homeless patients registered currently within the Guildhall Walk. As we've talked to HOSP previously, we've been developing services closely with public health for a more outreach-based approach to supporting homeless services. That's continuing. That's going to be managed by the primary care network, of which the Guildhall Walk practice was a part. And so we are working closely with them to ensure that those homeless patients receive a smooth transition, and how we identify. Obviously, we can do it from a technical perspective in terms of allocating them to a practice and allocating them to that outreach homeless service. But we also need to work with that outreach service to make sure that they are having those conversations with the patients as well as our PHL. Some of them we've got mobile phone numbers, etc. So using a variety of communication to make sure that we are working with those patients to support that. I think we've, during the pandemic, working with the local practices under that Brunel primary care network, we've developed some good services under that outreach, and we've been able to ensure, and we were actually a sort of a leading edge in the city around this, about how we've vaccinated the homeless residents. So we've built better relationships and have better service provision, I think, now than when Guildhall Walk was first commissioned, and that was the sole provision for homeless people in the city. We have a more robust offer, I think, moving forward. You asked about the special allocation service, so I just wanted to pick up on that. So the special allocation service, absolutely right, is provided by the Guildhall Walk provider. That's a company called PHL, a group of GP practices. That service has always been commissioned not just by Portsmouth, but by other CCGs within Hampshire and the Isle of Wight. So they use the Guildhall Walk practice as their base, but actually that service covers a much broader provision for a range of patients. The contract was different to the Guildhall Walk contract. So we commissioned, alongside other CCGs within Hampshire and the Isle of Wight, a separate service around special allocation service for those patients. That service was also coming to an end, but again, we're continuing to work with other CCGs and PHL to continue that provision moving forward, and working with PHL on an offer as to how they can continue to do that for us. So the site may change, but we envisage that the provision will continue for those patients, not just for Portsmouth, but for other areas across Hampshire and the Isle of Wight. They'll be moving to more of a digital model, again, using the learning from COVID around that. So there were some of the things I think perhaps to highlight from the report, Chair, but happy to take any questions.
Thank you, Joe. Councillor Wood, I think you had a question.
Hi, Joe. How are you? Good to see you, and thank you for the report. And I knew you were going to answer it. I think what I'm just trying to point out, as a councillor used to dealing with the mix you've got to deal with out there, is things delineated by boundaries don't actually work. It's a blurred line. And I spotted straight away several things about patients there with certain attributes in society that could lead to a lot of things going wrong. And the reason I asked the integrated care service, in a way, what the future is looking like, if you see what I mean, and you, if you like, representing currently what we do, is to just make sure when you say you're going to continue, I want the future people to be aware of the sorts of things they need to be taking on board, because I obviously was aware that it is several CCGs commissioning that as a sort of thing, and in a way, those are things I'm expressing my worries, Joe, that a time of change when we're used to people delivering good stuff, and I know you very well of that one, and then things change, that's where things go wrong, if that makes sense to you, about for all the best plans in the world, the transition for all of our CCGs or what have you will be the issue. So we actually, from the very start, need to be questioning the bodies likely to be in the frame to say, how are they going to monitor things that are already an issue, etc. So that was my point. So I'm not really asking for an answer. I'm just simply saying those are things I really want us to be aware of during this change as a HOSP everywhere in all our councils, that anything that changes, we need to monitor that change and make sure it's covered. Thank you, Chair.
Yeah.
Thank you. Councillor Lynn Hook.
Thank you, Chair. Thank you, Joe. I've just looked at one of the questions and it said, will I have to wait longer to see a GP if practices will have more patients? And I was interested in the longer wait to see a GP. We had the same problem with Brockhurst Medical Centre closing recently, and we only had 5,400 being dispersed all over other places. And we are finding, certainly over here, that our doctors in Gosport are very reliant on e-consults. They do not want to go back to the old-fashioned way of seeing their patients, and I'm very concerned with that. And I see in the question it isn't expected that the waiting times will be impacted. Should the question have been, should it be on an e-consult rather than see a GP? We're very concerned over in Gosport because we've been told in one practice the answer will be never. And I know that's not to do with Guildhall Walk, but we are very concerned over here.
Yeah, thank you, Lynn. I think through COVID we have developed. We were put in a position where we had to develop alternatives to normal face-to-face provision, particularly in primary care, and to move to what we call a total triage model. It was something we were working on anyway, to explore different types of access to primary care. And when I say primary care, I mean primary care in its fullest sense. So not just GPs, but other members of the multi-professional team. So that could be pharmacy, that could be nurses, nurse practitioners, paramedics working within that primary care space, or alternatively physios and OTs. So a range of professionals making up that primary care service. And this was something we were working on under the long-term plan prior to COVID, and recognising that some of that demand can be managed differently, digitally or through telephone triage as well. So there is definitely a place for that. all practices work very, very differently, but what we're seeing is that, you know, GPs are still seeing people face to face now. They're going back to seeing people face to face where there's a clinical need for that. But also, it's not just about seeing the GP, it's about seeing another member of those multi-professional teams. And one of the things we've done in Portsmouth, working just as an example, and this was pre-COVID, working with Solent NHS Trust and our primary care practices in the city, was to set up a primary care MSK, a multi-specialty, a physio service, basically. Sorry, apologies, I always get that word wrong. But a physio service. So rather than having to go and see your GP and then be referred to the physio, we worked with practices and their receptionists to say, actually, for these types of conditions, we can refer straight to the physio. So the physio would see the practice, would see the patient on the day, or would speak to them. It wasn't always a face-to-face, even then a face-to-face appointment, but would speak to them and be able to provide alternative provision. So they're the sorts of things that we're looking at, and that we have been looking at in the city and will continue to look at, and to share and work with partners across Hampshire and the Isle of Wight and their primary care services as well. Specifically in relation to the Guildhall Walk, what we've been doing is managing those patients where we know we have practices with additional capacity in the city, and we'll continue to work with them to ensure that they are supported to manage those patients, to take on additional patients, that they feel comfortable to take on those additional patients. So far they all have said that they can, and again we'll continue to work with primary care through the PCNs to look at access as we move forward, recognising that it's an issue, recognising that there are challenges with eConsult. It has a place. Sometimes it's really, really convenient. What we're seeing also as well is it's creating additional demand on primary care. So some of the things perhaps you wouldn't have phoned or made an appointment to see your GP, having that convenience of eConsult, we're getting all sorts of different questions coming through. So we need to think about how we manage that, because actually then that's taken up a huge amount of GP's time to deal with that perhaps previously they wouldn't have had to. So again, how do we get the right support to people using the right skills and expertise? I hope that answers your question, Councillor.
Thank you. Rob?
Yeah, sorry, sorry, Lynn, that was a good question. And Joe, you gave an answer. It's just spurred me onto the thing. Just talking about the attributes. I mean, I couldn't help notice, because I do data crunching myself. Okay, it might be wrong, but in isolation, looking at those figures, a lot of them were young people that went to that. If I look at the age demographics that did the walk-in at the Guildhall, they literally reflect a walk-in of young people. So one of the things I'm just interested in is, young people don't normally sign up to, you know, other practices unless it's right dead easy. So we already know there are young people, maybe students or similar or that working age, and there may be really vulnerable young people who don't want to go anywhere else and want anonymity. I'm just worried that you're making sure in spreading them around that they're appropriate for the people that they're trying to serve. So involving the university, you know, if you say, we think a big number of these are your students who are just here temporary walking. Have you factored that in? I mean, that's probably true everywhere else where people are migrating from walk-ins to fixed existing, if that makes sense to you.
Yeah, no, it does. Thank you. So they certainly, the Guildhall Walk currently isn't offering a walk-in service in the way it was originally commissioned to do so. Some of that provision was taken up through the Urgent Treatment Centre at St Mary's. So it has a very fixed practice population, but you're absolutely right. They are a quite a young population, quite a transient population through the city as well. We have. So that brings perhaps different challenges. You're right, and maybe linked to why we haven't seen so many as perhaps we thought express a preference for and have allowed us to do that. We'll be able to monitor and work on that in a number of different ways. So yes, we have worked with the university in relation to this. So we've met with them. We know We are working with the university practice, or uni city practice, as it will be known when it moves to its new site, to because they have quite a bit of capacity to take on those patients. We have what we call a basket of services for each practice, where they have perhaps unusual patient groups, which, if you look at the demographics of Guildhall Walk and the university, it's a much younger population, so they have different needs, and within that we work quite closely with the university and the uni city practice to make sure we've got the basket of needs right for that student or young people population, because they won't all be students, but if you've got those services in place for the students, that other age group can benefit from that, even if they're not actually associated with the university. One of the things the university has told us is around, particularly at the moment, is mental health support in the city for their students. So we're working with them and the uni city practice to look at that and think about how we can move that forward. So that's one area. Again, the reason we've worked with the Guildhall Walk practice to identify those more vulnerable patients, some of the types of patients or the concerns you have should be met in that way through that work, identifying specific patients and making sure there's different communication with them based on their needs, and that they're flagged with the receiving practice. We've also just confirmed that we've only been fortunate, we've only had to do this once in the city previously, at Queen's Road about 5 years ago. That practice manager still works in the city, and she has agreed to come and work with Guildhall Walk and the other practices to manage that transfer. So she's got experience and learning from what went wrong. So we think that's going to be really helpful to make sure that we can support those more vulnerable patients, and that nobody with ongoing needs gets lost in that transfer process, because we'll be able to flag them.
Yeah, sorry, Chair, if you could just bear with me. Thank you, Joe. That's very, very, very detailed. I guess I'm trying to make sure that, in a way, the Guildhall practice was a successful practice for what it was serving, if you see what I mean. It built up quite a good practice, and therefore it's specialised. I guess in the transfer, asking the opposite question, the question you were talking about, which is saying, why aren't you transferring, you know what I mean, to a group of people? Just, I know it's a straw poll and you won't get everybody to answer, but in a way, adding to your person who's managing the transfer and making sure it's happening, just to get a straw poll of the opposite. I'm just, as I said, I want to make sure that in the move, it's very easy in the move to do the job, which is get them transferred, but then forget this was had a unique blend here, and you need to ask all those people who haven't moved, if you don't know, if you've tracked them, it's just worth doing a straw poll to say, we notice you haven't moved. Is there a reason?
Yeah,
don't know.
Apologies, maybe I've misinterpreted, perhaps I haven't been clear. So for those patients who haven't expressed a preference of choice, we will allocate them to a practice, so they will transfer and they will be informed of their new practice. They will then be able to contact us through the inbox we've set up if they have any concerns about that in particular. We will be working with all of the patients of Guildhall Walk, all of their current patients, to make sure that transfer happens smoothly, and using flags on our system so that the receiving practice is aware of how that will happen. But yeah, you're absolutely right. If somebody has moved to a practice and then feels that's perhaps not the right fit for them, they are then able to change and move practices. And we see quite a lot, and we monitor it as well, quite a lot of move of patients all the time between practices that we monitor, and we work with practices as well, particularly if we're seeing higher numbers of patients move from a particular practice. So we use that to work with them and provide support.
Thank you. Councillor Arthur Agate, you had a question.
Thank you, Chair. I really should put it over the microphone when I'm about to speak. The question is, you on, I've got page 100 here, long COVID, that you have a facility for Portsmouth residents. What type of area will this facility serve?
Apologies. So that's in the next agenda item report. Are you happy for me to move on to that, Chair, or do you want me to stick? That's if
you stick to this Guildhall Walk, and then I'll let Simon do the next one.
Oh no, it's me doing both.
Oh, are you doing both? Okay.
Yeah.
No problem. Maybe we can move on to the next one if you're happy to.
Yeah. So just picking up that we've supported the question. So long COVID is obviously a very new issue that we are having to deal with. We are commissioning that service and working with providers across Hampshire and the Isle of Wight. So there's a real framework around that. It's based on a multidisciplinary team clinic with referral in. So any GP from across Hampshire and the Isle of Wight can refer into that service. So it's a multidisciplinary team, and it is a very new area, so it's very much in development. At the moment, we're linking it to services like chronic pain or chronic fatigue services, perhaps ME type services, because some of the symptoms people are having are similar. There's a lot of research going on around scans and diagnostic support that will help this, and we're again working with all providers to continue to develop this service, recognising that our understanding of long COVID is still fairly new, and it seems to be affecting different people differently. So we're trying to develop a range of support and working with patients. One of the things they've done is develop an app for patients so they can track their symptoms and how that is affecting them on a daily basis, again to get a better understanding of what it looks like and how to best support it. It's quite a complex area.
Thanks, Joe. It was interesting for me because we'd gone through safeguarding earlier, and South East Hampshire and don't come under the Portsmouth safeguarding thing, and it was interesting to make sure what area this particular facility was going to cover. Thank you.
Yeah, so on that one, it's definitely a Hampshire and Isle of Wight service. Would you like me to give any further update on the agenda item 10, Chair?
Yes, if you want to go ahead with that, that's great. Thank you.
Yeah. So I guess just points to note really, and perhaps picking up some of the issues that have already been discussed earlier in the meeting. I think the two areas I'd like to talk about are the systems pressure, but also the ICS development, because I think perhaps that goes some way to answering Councillor Wood's concerns around how we're working as part of the ICS. So if I start with that, as we know, Portsmouth CCG made a decision, and I came and spoke to you at the previous meeting, around maintaining as a single CCG at that time for the foreseeable future. Obviously, since then we've had the guidance. We know that CCG functions will transfer into the ICS from April 2022, but that the provision, and as Richard said, within the guidance that was released recently, the emphasis is on place and place-based partnerships. That's really important to us in Portsmouth. I think we have really good partnerships arrangements between the NHS in its broadest sense. Apologies, my dog. Just bear with me a second while I shut. Apologies, joys of home working. My husband came home and set the dog off, so I do apologise, Chair. Yeah, so that place-based working is really important to us, and we recognise that Portsmouth is a very central tenet of the ICS. We have to work really in and deep with our local communities within the voluntary sector and with local people. And we also need to look up and out into both Portsmouth and South East Hampshire, which we've also always done, and into Hampshire and the Isle of Wight. So we are continuing to work really closely to understand what place-based delegation will mean for the city in the future, and what we really hope it will mean is that we continue to have delegated responsibility between the ICS and the local arm of the ICS and Portsmouth City Council, so that we can continue that integrated approach to planning and delivery that we have at the moment and continue to strengthen it. We met with the Health and Wellbeing Board and our provider partnership, which includes the Hive and our primary care partners, as well as Portsmouth Hospitals Trust and Solent NHS Trust and the local authority. We had a meeting last week to look at what does that mean for us in the city, and how do we develop, and what do we want from the ICS. So we're continuing to do that and continuing to work at all of those three tiers: the local Portsmouth place-based tier, the system around Portsmouth and South East Hampshire supporting our acute hospital, and then working very much as part of the ICS, and seeing that actually Portsmouth teams within the ICS may take on a leadership role for some areas of provision or planning and commissioning across Hampshire and the Isle of Wight. And that might not just be ex-CCG staff who will transfer into the ICS, that could be local authority staff. So we know that locally our Director of Children's Services and her team commission on behalf of the CCG currently. We would expect that to continue, and we would expect that team to perhaps be leading areas of Hampshire, commissioning and planning work on behalf of Hampshire and the Isle of Wight. And we're seeing that already. So really wanting to get the best out of this and to strengthen the integration we have in the city at a broader level as well. So that's what we're hoping for from this, and that's what we're working with Richard and the broader teams as well. In terms of your concern, Councillor Wood, around that organisational history and legacy, I think it's fair to say usual rounds of NHS reorganisation can see that disappear almost overnight, can't it? I don't think that will be the case with this transition. There has been an employment promise to all staff affected by this, so all staff from the CCG will transfer into the ICS with the exception of board level staff, but for all of our staff that support will continue. So we will continue, I think, to see that partnership way of working and approach in the ICS, and particularly locally in the city. The only other thing I just wanted to mention, we've talked a lot about system pressures in Hampshire and the Isle of Wight, and particularly in Portsmouth hospitals. We continue to work with all partners to support that and look at where we can change pathways and improve our management of on the day demand, and given some examples about that already. So we're continuing to do that, working both locally in the city, but also in Portsmouth and South East Hampshire, and seeing what can we learn together across Hampshire and the Isle of Wight. Sorry.
Thank you, Jo. Does anyone have any questions? I know Councillor Cartwright, you have to leave soon. No further questions? Thank you then. That's the end of the meeting today then. If you'd like to note that the next scheduled meeting is Thursday, the 16th of September at 1:30. So thank you, everyone. And can I just remind everyone to not say anything at the moment while the live stream is switched off? I think Lisa's just going to do that.
Yeah, I'll just go and turn it off, Chair.
Thank you.
Okay. Chair, can I just say one thing? Well chaired. Okay.
Thank you.
You are a newly elected member. That was well chaired. Thank you.
Thank you. It's the first time I've